talk about how to bring in a discussion around relationships between tribal and local health departments. And so we thought maybe a panel discussion in the middle of the day, kind of to break up some of the training and to get some of that dialogue going, would be a good thing. So we have a panel, and on our panel we have Tom Anderson, who's going to go first, and each one of them is going to do their own introduction. So we have state perspective from Tom and from Sally, and then more local from Anna, who's a fellow accreditation coordinator, and then Laura Sonny Spencer, who's going to talk from Cherokee Public Health. So we're going to go ahead and get started in the interest of time. Couple of things. You guys have evaluations in your folders, and you really have to do those because you just really have to do those. So please do those. And if you could just put them face down on the table in the back when you're done at the end of the day, that would be great. And also, you should have note cards in your space. And the note cards are for questions. So if you have questions during the panel, please fill those out and pass those to the end of your table. And at the end of the panelists giving their 10-minute spiel, I'll go and get those, and we can read some of those questions and get that dialogue started. Okay? All right, Mr. Anderson, would you please start us off?
Well, good afternoon. I hope this is working. My name is Tom Anderson. It's a pleasure to be a part of the discussion here today, having tribes included. And we appreciate Lynn's foresight and Dana's and all the other planning committee personnel that were involved in this. My name is Tom Anderson with the Oklahoma City Area Intertribal Health Board. We have a duty and responsibility to represent to some degree the health interests of the tribes, federal recognized tribes in Oklahoma, Kansas, and Texas. Why do tribes matter in accreditation? We know that they can be accredited or achieve accreditation. And I think that all of us have some experience working with tribes, and some of you can share some of the most wonderful, best experiences of your life, and on the other hand, some of you can share with me some of the most frustrating, exhaustive, empty feelings as well when working with tribes. Why is that? How can that be so different? How can you have your relationships be so divergent? And hopefully we can maybe take a peek in how we, as accreditation experts or thinking about accreditation, how can we be responsible and do our outreach better to tribal people to make it work for everyone. I want to digress now and tell you a little bit about the Oklahoma City Area Intertribal Health Board, specific, the Tribal Epidemiology Center, which I am the director of, and what their role is and how it may facilitate some of your effort. Tribal epidemiology centers were created with this premise. Several years ago, being more than 30 years ago, tribes addressed this issue about reporting to the federal government, saying you collect data, you analyze data, you report data, and you write our health story based on this information largely. We think that's a role we should do. We need to advocate for ourselves. So the seed was planted, and the federal government agreed and said, let's start with this effort called Tribal Epidemiology Centers, where they serve your interest under the umbrella of a area health board. So around the country where there are tribal nations, there are 11 plus one more, 12 TECs. The 12th one serves the urban centers largely in the country. What we do is we stand ready to help tribes write their health story using this foreign language called data. We help them try to be better in some instances. And also, we serve as an advocate for a lot of the tribes that do not have that person to help them advocate for their infrastructure and capacity needs. I tell you that to bring you up to what we're talking about today, public health accreditation standards. As you know, tribes can be accredited. And Laura will address one tribe that is leading the nation in that effort. But I want to go back and try to interplay with you this role of where TECs may facilitate your effort as a local health department, as a state health department. About a couple of years ago, we were attempted to work with a state, one of our border states that we represent here, and they had for years said we are unable to share data with you. We do not recognize you, and we are a closed record state. We can't share American Indian data with you. And then something happened called accreditation. The state went through the process of being accredited, and they learned that through the process they had to do outreach to the tribes. They were forced to. And with that, the dynamic changed to where the Tribal Epidemiology Center was approached to help them with a first ever public health conference, and also to serve as a data repository for American Indian data. And that brings me to a more current or recent impact. A part of the Affordable Care Act was a rider called the Indian Health Care Improvement Act, and there was specific language in this Indian Health Improvement Act pertaining to tribal epidemiology centers, TECs or TECs. And it states that the federal government will recognize these 12 TECs as the public health authority for tribes when it comes to performing 7 specific functions, and they're delineated in the law. The federal law now states that the federal government recognizes TECs now to be the public health entity for the tribes. It means that we have some tribes that have their own public health department. We do not usurp their effort, we facilitate their effort. And largely, the law went on to state that data that's held on American Indians pertaining to those tribal partners by the federal government through the divisions of Health and Human Services, and that's a whole array of departments, right? Indian Health Service, CDC, SAMHSA, HRSA, and all down the line. There are about 12 departments. They are to share relevant American Indian data in their repository with tribal epidemiology centers. So now then, with that in mind, we are here as a representative of a tribal epidemiology center here for Oklahoma to tell you this, that we are here to help you, should you choose, with the accreditation process. TECs cannot pursue accreditation because of the format in which is mandated for tribes, not tribal organizations, to be accredited. I want to make one other footnote here. Sit back to the other state that I was telling you about. They're going to be hosting their 2nd annual public health conference. We have helped them with their effort with some of the tribes on the community health assessment. First step, arriving at their community health improvement plan. And we've been asked to participate in their 2nd annual tribal public health conference coming up in August. So it's amazing how things can turn out rather rapidly under the name of public health accreditation. So we're excited. It's a new effort. It's a new recognition. Not a lot of people know about it that are in positions where they should understand that with this federal statute comes responsibility for us. And remember, our effort is different than Indian Health Service. They are a partner, but they are the federal side of data collecting and data gathering. The Oklahoma City Area Intertribal Health Board leadership and its members are composed of tribal partners, tribal input. That's who I serve, is our tribes. Indian Health Service serves the government. Our effort is attempting to advocate on a lot of different levels, tribes to be able to write their own health story, and including accreditation. So I want to make that distinction. Now then, the illustration, tribes can be the most wonderful partner you do outreach with, and they can be the most frustrating partner you do outreach with. And it can be the same tribe. Depends on what you ask and how you go about asking it. And I tell you that because I feel compelled to share with you that often we aggregate minorities as one group. In my mind, it's an error. You're making an error when you do that, because you have to differentiate. American Indians are a special population as defined in the Constitution, in Supreme Court rulings, in other laws. Remember that they exchanged land and natural resources for certain things that the federal government promised to them. And also remember that American Indians were here prior to a federal government, and those obligations and those treaties still remain. So that has relevance on why we're here today and in our conversation. I believe they are a special population, and I think that I see my time's gone. So, but I want you to make that distinction that they are different. The last point is they're the only minority that has to prove it through blood quantum or through some type of. So, thank you.
Thank you. And now we're going to hear from Sally. But I mean, that was a wealth of information that I did not know. So me personally, in moving forward with accreditation efforts, just that distinction between IHS and the Tribal Health Board is very significant. And so, Tom, we can call you to get anything that we need, and you're going to do the connecting for us.
You can get an answer. I'm not sure it's the right answer.
We appreciate that. And Sally?
Thank you, and thank you, Tom, for your insights. I certainly appreciate it. I'm Sally Carter. I'm the Tribal Liaison with the Oklahoma State Department of Health. And I do go to Tom and seek his consultation on a regular basis, and really appreciate the partnership that we have with the Intertribal Health Board, and the health board members themselves has really made our work much easier as we've been moving towards our statewide accreditation as the State Health Department, and working at the county level as well. I have a handout that was placed at your table. It's the importance of promoting collaboration between tribal and state public health systems. And on the back is the tribal jurisdiction map. One of the things along some of the same lines that Tom was really doing a great job of articulating for us, I did a lot of work on when the State Health Department became accredited, and we were visiting with our site visit team, and they were really struggling with the fact that in Oklahoma that our tribes are not reservation tribes. That was a concept that was really new to our team members, and we spent a lot of time trying to explain what those differences are on so many different levels. And I think it's important for us, and that's why I always bring this map with me just about everywhere I go, for us to be looking at those jurisdiction areas. But for example, if I went out to any of these jurisdiction areas, I can go buy a house in any of those communities unless it's actually tribal land. And so in other states, I was visiting yesterday with someone who was from the Navajo Nation, and that is a reservation tribe. And that is a very different situation. So I think it's important for us to understand that we are working government to government. We have an unusual setup here in Oklahoma as compared to a lot of other states, and it takes time to learn these things. My role as the state tribal liaison is truly to help us in this government to government relationship that we are doing. And I do want to recognize Michael Piercy and his colleagues from the Chickasaw Nation that are sitting over there. We are so glad that you're here today, Michael, and colleagues. We do a lot of partnership with Chickasaw Nation. Of course, Cherokee Nation helped us enormously when we were doing our accreditation, came up and actually visited with our site visit team, and we have shared documentation and information back and forth as we've both been navigating through our accreditation efforts. First and foremost is the State Health Department employees that are here. I do encourage you to look at our tribal consultation policy. That's posted on Irene. It's 1-39, and it really gives you some basic information there about some of the obligations that we have as state employees in terms of guidance that the Commissioner of Health has directed us in terms of leadership's intent that we do partner and collaborate with tribes. And we actually spend a lot of time trying to talk about the word collaborate. It's not just consultation, it's a partnership. And, you know, Tom talked about relationship, and that's what I spend a lot of time thinking about and trying to work on, because a partner is someone who comes to the table as a decision maker, who is working with you, as we all are, in terms of improving the health of all Oklahomans. That's the purpose that we're in public health, and the public health programs within the tribe. That is our common mission that we share. And it's important that we think in advance, that we're bringing tribes in very early in our assessment process and in projects and grants and everything that we're doing, so that we can seek their guidance, their input, their direction, their experience. And talking about some of the difficult issues like data sharing. Michael Piercy is an epidemiologist within the Chickasaw Nation. I'm often calling him, and we're navigating through concepts of data sharing agreements and the limitations that we have. Most of the data that we have at the State Health Department is state level data. The Cherokee Nation has been working a lot with us this past year about wanting to get county specific data or their tribal jurisdiction level data, and the numbers that you need to include in being able to collect that amount of data. There's a lot more people that you've got to talk to be able to get that amount of specificity in the data. It's more expensive, it's more time consuming, there's a lot of challenges in terms of the analysis that goes along with that. And those are things that we partner with. So for example, we have state EPIs in the State Health Department that will sit down with our tribal partners. Tom, in his role at the Tribal Epicenter Director, comes over and meets with us as we try to navigate through all these sorts of issues. So as you're trying to look at data at the local level, we encourage you, give me a call, of course, give Tom a call. We want to help you through that process, because it can be very, very challenging, and we can share some experiences and hopefully give you some guidance. We also think that, just like you were saying earlier, there is a complexity to the Indian health system. I'm not saying Indian Health Service, I'm saying the Indian health system. So for example, we have Brandy here from the Lawton area, and the services that are provided down there are from Indian Health Service. There's the Indian Hospital there in Lawton, there's a clinic in Anadarko and a clinic in Carnegie, but those are IHS facilities. We go to Cherokee Nation, they have their own hospitals and clinics that they're running. There's other tribes where there's compacting, where the tribe may have built the facility, but IHS may be staffing that facility. So really trying to learn all of those different ways that the Indian health system functions. It takes a long time to learn that. It certainly took me a while to get into that. Also, the cultural competency training, I think I wish we had a whole session from Tom and others on this panel today. I've been working with the tribes for over 20 years, and every day it goes by, I feel like I know less and less. There's so much to learn And it takes a while to learn that information. You have to be proactive, you have to be motivated, but frankly in our state, we have a very large American Indian population here, and I think it's our responsibility in public health to make extra efforts to reach out and partner, collaborate with our tribal nations, understand the health disparities that are specific to American Indian people, the challenges to access to care. And when I talk to Rear Admiral Meeks with the Indian Health Service, he often reminds me that IHS is funded at about 50% of need. I was talking with Robin Sunday Allen. We were at her place at the Oklahoma City Indian Clinic the other day doing a maternal and child health listening session. And she says, well, for our clinic, we're funded at 25% of the need that we have to provide the health services for people in Oklahoma City. And while we have these 38 federally recognized tribes that are on your map, she says, well, we do about 100,000 encounters out of our clinic, but we serve people representing over 200 tribes in our state. So while these are where the headquarters are, please remember this is a mecca for American Indian people living here, families, both in our urban and rural settings, and there's not any one person who's going to speak on behalf of tribes or any one person who knows the American Indian perspective. It's not enough to have one person that sits on a coalition or a group that we're working with and expect that person to be able to speak and know about all things related to tribal nations. One of the recommendations I have on my sheet is for you all to understand the importance of going to, like, say, for example, one thing we've done with the Chickasaw Nation is we've been in discussions with Dr. Judy Goforth Parker around some of these accreditation efforts. And I think it's important that we have the health director give us their official designee to work with us in some of our local assessments and planning efforts. They then have the authority to speak on behalf of the Chickasaw Nation. If we have someone who's on our coalition that may be a nurse that's working in a tribal clinic or something like that, they may not have the full authority of the nation to be there as their representative. But if Dr. Parker has designated someone, then she's going to be giving that person the parameters in which he or she may speak on behalf of the tribe, the decision that they may be making. That designee would be coming back to her for guidance and consultation about next steps. And just like I can't go sit on a committee and say I speak for Dr. Klein or I speak for the health department unless I am that Dr. Klein's official designee. Sometimes I am, but 90% of the time I'm not. And so we have to be very careful that we don't place a burden on someone who's American Indian in our community. They sit on our coalition and we assign them that they have authority that they really do not have. And I think that's just really important, that if you don't know how to make those contacts or you need the right person to talk to, who would you reach out to? That is my job as your tribal liaison, to help you discover who that person is and how to establish those relationships. I think probably one of the most important things is this point I've discussed about being at the decision-making table. I think a lot of times I'll get calls into my office and someone will be writing a grant and they'll say, we need a letter of support from the tribe. And I'm saying, well, did you send them the application? Have they been on your grant writing committee? Are they going to have a role to play? Are you serving the American Indian population with this grant? Will they receive part of the funding? Have they developed the budget? It's really, for me to be able to get a letter of support, it's more important that they are a true partner, that they are really there with us every step of the way, and that they are helping us to craft the intervention, the best practices that we're going to use that are actually going to benefit all of the members of our community, including American Indian people. So I just think that, you know, when I had to try to think what are, in my 10 minutes, what are the most important things that I wanted you to have as a take-home message, is to know that the Office of the Tribal Liaison at the State Health Department has been designed and established to be of assistance. nothing has to go through my office for permission. We're not a bottleneck. Nobody has to send anything for us to look at or approve. It's more about if you want resources, if your staff needs some training, if you'd like to have contacts within the tribes. Likewise for the tribes then, they may contact me if they're trying to navigate any service that we provide within the health department. It could be that they're needing a certificate of need for a nursing home, a skilled nursing facility that they're going to be putting in place in their area, or a patient with tuberculosis who's not taking their medication, or we recently had some work with the Citizen Potawatomi Nation for an event that they were doing that was involving tattoo artists that we needed to help them with. So really, my job is to be of assistance to both sides, but in no way am I, in any sort of like you have to pass things through us for any type of approval or acknowledgement. We're here strictly to help. So I appreciate the opportunity to be on this on this presentation today, and I do have at the bottom of the sheet there my contact information if you'd like to reach out.
Thank you, Sally. And also, we didn't mention that you should have a business card for Tom at your table as well for his contact information. Okay, Laura.
Okay, good afternoon, everyone. Thank you for having me here. I'm Laura with the Cherokee Nation Public Health. The accreditation coordinator / performance improvement manager is just one of the couple hats I wear there. And so since this is about accreditation, I'll be talking about accreditation. I brought a few of these, so you should have this visual, but I will be emailing, and so I guess you guys are going to post it on your guys' website. But what I wanted to, to discuss about with you guys here, because this is a great opportunity to be able to talk to the people that are on the ground, and we do have wonderful relationships with the state. Geographically, though, since there is some hours and some miles in between, it's really at the local. I think local health department is where we can really to solidify the collaboration and to really do that partnership. And so on this timeline, this is just our experience of going through the accreditation. So you can see that kind of how we've taken things. We use the MAP tool process in order to get the 3 prerequisites. And I think for most tribes, I think that's probably going to be the hardest and most time-consuming to do, is to get those 3 prerequisites, which is the tribal health assessment. And we just talked about data. And I know for Cherokee Nation, that was one of the, again, most time-consuming. When we thought about it, we were like, oh, we can get this done within 6 months and whatnot. But when we really started looking at that, we really did not have that infrastructure in place. And when we began this journey in 2011, and probably a little bit before then, but really took the ground running in 2011, it took us a long time to get that tribal health assessment. And without that data and that information, you really can't move forward, because you have to have that snapshot. You have to know where you're at before you can know where you're going. And so I think that could be a critical piece to where local health departments, and it kind of just funnels up to the the state health department. But I think that that's a critical piece where we can partner, because honestly, Cherokee Nation has had several years to try to develop our infrastructure. But for the most part, most tribes are not going to have a well-established public health infrastructure. So what I guess my message would be to the local health departments along with the state, but again, mainly this local health departments, because you guys are near to the communities. And so is to reach out. I think for these next few years, as tribes put more effort and more resources into trying to establish public health infrastructure, I think that these first few years, it's going to really take the state, the local health department side to really say, hey, let me invite you to these things. It's not that they don't want to do it, but again, for the majority, I want to say greater than 90% of the tribes are going to need that holding the hand type of thing. And you guys have established, the local health department, the state health departments, have a strong system, a strong infrastructure already built. And so I think just again, encouraging, inviting, and then as the years go by, I think that you'll start seeing that mutual beneficial relationship really start to grow. Tribes have resources. We have people resources. We have tribal resources. monetary, but also other things that I think that we could contribute. But again, it's establishing that relationship and getting the tribes to see that this is doable as far as public health accreditation. I know, looking at this, thinking about hindsight, we were just like, wow, how are we going to get this done? And I'm sure a lot of tribes out there are in that same situation. When you look at the standards, when you go through the manual, you're saying, there's a lot of things that we don't do here. Again, and even going back to the data, we, a year and a half, I believe, that we spent on trying to collect data and getting the story that we wanted. And actually, we had to at some point say, okay, we're not going to get the true story that we want, because there is a lot of issues to getting down to that type of data. Is going to take a lot of work, but I still think that that's something possible in the future. But again, I think it's just going to take teamwork from the local health departments, and then again with the state health departments, to be able to delve down to those specifics. So we have a 3-tier system that we use, the general population within our 14-county tribal jurisdictional area, and then American Indians, because for the most part, we serve American Indians within our clinics, and so there isn't too much Cherokee specific. And so, and then when we can, because it is Cherokee Nation, we would like to know our story, our snapshot, and when we can, although very limited, we do like to try to get that data information. And so, but again, I think that we could partner up, because even I know at the local health department level too, that it is also limited. And so I think if we pull our resources, our people resources, that if we're going through a health assessment, a community health assessment, I think if we could work together, I think that we would be able to cut the time in half. And again, that would also pull in the tribes to be able to start that initiative. So that's when I thought about, okay, what am I going to speak about, since I have this audience of the local health departments, is that really, again, just taking that time to invite, because there may be, Cherokee Nation is very blessed to be able to have a lot of people with experience and education background in public health, and that's not always the case in the tribes. So again, kind of just doing that mentoring and inviting, and again, because I think that tribes are going to need a little bit more push. We're used to thinking on the clinical side. I know for Cherokee Nation that had been some of the efforts that we had to do, is that we had to really educate our leadership. And so not only would you guys help in the facilitation of educating leadership, because sometimes hearing that third party person is very helpful, because tribes are small. We always say Indian country is small. And so sometimes hearing that third party saying, yes, public health is critical, public health is necessary, prevention services is necessary, can be very beneficial to the people who are working in the health department. So again, it's just reaching out, and not to be shy about that, because I think we need to develop those champions within the tribes in order to do that. And for the ones, like I know Chickasaw is, there are a few tribes out there that are ready and ready to go, but again, it's just knowing where to begin. And sometimes that's kind of hard, but I think with that partnership, getting them involved in little steps at a time, I think that could be very critical and crucial, and to be able to further tribes and wanting to achieve accreditation. And again, the results and outcomes can be beneficial, because we are dual citizenships. We are tribal members, but we're also members of the community that that everybody here works for. So, and we take pride, at Cherokee Nation, is that our efforts, our services, our outcomes and results not only benefit Cherokees or American Indian, but we benefit everybody. When we work with community-based organizations, when we work with schools, it is like we kind of consider ourselves like another local health department, because we make sure that all of our services is for the community, because we cannot change the environment without impacting everybody. And so, we want to be good neighbors. And so, again, I think that we can really benefit and use resources wisely and together if we want to look and try to bring it. But again, I think for the first few years, it's going to take the local health department, the state health department, but local health departments on the ground to really reach out and start inviting and teaching, because like I said, honestly, I don't think that a lot know about public health. They may hear about it, they may be a little bit excited about it, but again, don't know too much about it. So that's what my words would be for, is in these steps to reach out, and every bit as you're going through your accreditation process, to reach out to tribes. And I don't know how much time, I didn't see anything yet, 1 minute. I know that in the standards, there are specific standards and measures that can really promote this. So again, I encourage it, and anytime I get to speak with tribes, I also encourage this in that part, is that take those standards and use those as the tools for your leadership, and on the tribal side for that leadership to say, hey, here is the reason why we need to do this. So I think using the accreditation as a tool to pull us together, work together, collaborate our resources, I think is going to help all of Oklahoma, and all because we're going to be able to impact much greater.
Thank you, Laura. Very good information. Okay, Anna, you have some slides, and so you want to switch with me? Sure. You want to stand?
I can do that. I'm gonna stand because it helps me. And I need to be able to see my slides because that's how I organize my thoughts. I'm Anna Stuck. I work up in the north central part of Oklahoma. Can you guys hear me with this? Okay. When thinking about what I wanted to talk to you guys about today and about why I was asked to be sitting at this table today, I kind of focused on the interactions part of that. My history and my experience has been working some with my local tribes in a few different areas: prevention, substance abuse prevention, now in this job with accreditation, and then I also have the unique experience of having spent a couple years in the Peace Corps. So the idea of culture and our country and the different interactions of culture is incredible to me. It's one of the reasons why I do this job. It's one of the reasons why I love this job, and why I love living in Oklahoma, because as my other panelists pointed out, there are not many other places in the world where we get exposed to culture like this. So I'm going to talk to you just a little bit about my experiences on building those relationships from the local health department, and how we can really help build our accreditation argument by having these relationships in place. So starting with that culture thing, anytime I'm starting a relationship with anyone, whether it's a school, whether it's a tribe, I'm usually looking at three things, and these are three things that I was specifically trained on before I was sent into the Peace Corps. They make you spend a lot of time with this. It's the idea of language, calendar, and mapping. Obviously, when I was in the Peace Corps, language was a very literal thing. I was going to have to operate in Romanian on a daily basis. Here in Oklahoma, that's not what I'm talking about. I'm speaking about all of FAB and IHS and that kind of language. Your police departments, your military, all of them use their own languages, and you have to be aware of that, and you have to realize that you don't necessarily speak that language. And all of these, you're going to be coming from a place where you don't know. So that's a good starting place. It's just that you're going to go out and you're going to learn something about somebody, and it's going to be about them. It's not going to be about you. Calendar. A lot of my examples today are going to be about Moldova and Romania. So bear with me. I love talking about it. In Moldova, there is a 2-week period during the school year where you don't teach school. It's just the way it is. They're all out. It's wine country, and the kids are needed in the wine fields. So you can just cross that off your calendar. You're not doing anything those 2 weeks except going out and having fun in the grape fields. Your schools here in America, springtime. Do we do a whole lot with our schools in the springtime? No, they're testing. So you've got to have respect for that. You've got to realize that they've got their own priorities that particular time of year, and help out a little bit if you can. And then mapping. Mapping is kind of my favorite part. It's that exploration of the organization of whichever agency you're dealing with. Because we have so many different tribes, they all have slightly different organizations. So you have the opportunity to go out there and see how each individual tribe, I'm lucky, if you look at the map, I've got several tribes. So I get to go out and look and learn about how each of them have decided to govern themselves. And yes, it means that each time I walk into a room with a different agency or tribe, it looks different, but that also means I get the opportunity to learn about that. And again, that's cool. We're lucky we get that. So make sure that you're not just looking at your communities and the physical mapping there and where your resources are and how they interact with your tribal organizations and their agencies, but also with the organizational structure. So you've got the physical, and then you've got that kind of nebulous organization. So this is my game plan for working with anybody. Step one, show up and be useful. Learn about them by what they need and by helping them with what they need. Before I was an accreditation coordinator, I worked, like I said, with Department of Mental Health, and we did a lot of grant work. And sometimes that's something we didn't really have an opportunity to do because you're looking at grant funding, there's a lot of, it's about what you can get from your community, right? It's about organizing this in your sphere of influence. This is the grant I'm working on, underage drinking prevention. I need everybody to come to my table because this is what I have to do for my funders. I don't have, or I didn't have, a lot of opportunity to say, you know what, today isn't about underage drinking. Today is about the youth, you know, and going out and helping a tribe with a youth encampment that they're doing. And so being able to step out of what you need and start looking at what they're needing. And you're going to learn a lot about where your common ground is. A lot of our tribes are looking at accreditation. That's a lot of common ground. We're going to be looking at a lot of the same things. Several of my tribes are not ready for that yet. So our common ground is a little bit smaller, but it's no less important because they're working on tobacco cessation, specifically in Perkins. You know, that is where they are at right now. Well, that's great. I can work with that. And under the structure of accreditation, we can do that. So it's easy for me to go out to them and to be working with them on our Community of Excellence grants and to be able to work in those areas on that common ground. Oh, I already covered my second point. Man, I'm good. All right. I'm also nervous. And my third one is avoid pushing a poor fit. That is hard to do sometimes because it means sometimes you gotta let stuff go. I don't have a relationship with every single one of the tribes in my area right now. I don't have nearly the relationship that I want to have because I'm having to wait until I see an opportunity for me to show up and be useful. I'm waiting so that I'm not stepping on toes, that I'm not trying to force people to come to my table. I'm not trying to force that poor fit. It's gonna happen. I'm gonna run into the people. You know, I told Tom, I've written his name down several times in meetings with Sally and around. You know, I didn't necessarily march down to Department of State, I'm sorry, the Intertribal Health Board and say, well, you and I are gonna be best friends now, Tom. This works. And I'm glad I got to meet him today, and now I'll have that at least small bit of a relationship today. It's gonna happen. That's another Peace Corps lesson. Sometimes you just gotta wait, and it'll happen. But like Laura said, the accreditation is a great time to start a conversation. If it is something that they're interested in, that's a great opportunity. Jump on in there. So specifically, I kind of went through a little bit of the accreditation process and times that I saw that they were really asking for tribal collaboration. How am I doing on time? I'm sorry, I'm not even looking at you. Okay. Data collection and dispersal. We're going to want our relationships to be able to give and take that data. So you're building these personal relationships so that you have that line of communication. And that's going to expand out and it's going to solidify so that your emergency planning and your resources and your health education data have places to go when you're ready to do that, because you've developed these relationships, you know where to send it, okay? And that's it, right? That's Henry.
Thank you. Great information. Thank you guys for participating. Okay, question time. Any questions been passed to the end of the?
You're happy, Rick?
I absolutely do. He said, do you have any ready yet?
No, that wasn't I was asking if we had to write them or if we can actually just.
Oh, yeah, you can.
Can I ask one?
Sure.
I wanted to ask Tom. So to work with your organization versus a local tribe, is there a particular protocol that is best for us to operate under so that we don't alienate the local tribe by going directly to you or vice versa? What's the relationship like, and how best are we to navigate that?
Good, great question. That's a great question. Thank you. You know, we always recommend to do your outreach to the tribe. They're the sovereign, they're the government. We don't want to usurp you building a relationship with the tribe. In the event that you're having issues in making those contacts, we serve to facilitate that effort. We don't take the place of you building that relationship. I don't know whether I'm being clear on that, but if you wanted to reach out to us and you wanted to work with a tribe in Anna's area, we could make a recommendation. In Oklahoma, we have a representative that serves on our board representing all the tribes, all the federal recognized tribes. So they're a health board delegate, and then they also, back in their own area, they have frequent, usually monthly meetings that the area tribes get together. So we kind of would let you inform you who the representative on the health board would be, and then maybe you want to reach out through that entity to the tribe if you're going to, if it's a healthcare issue. Okay.
Thank you.
I just had one question. The Delaware tribe is now federally recognized in Washington County?
Well, here's my understanding. There are 38 federally recognized tribes in Oklahoma. When you talk to our governor or the state, they say we have 39 recognized tribes. So there is a discrepancy. It's my understanding there are 3 Delaware tribes that are federally recognized. Okay, so when you ask me what's their tribal jurisdiction, I can't give that to you sitting here. But I believe that Sally, maybe you know this, but I believe the Delaware tribe, if you're talking about up in Washington County, yeah, is a federally recognized tribe.
Because I do know that they used to be under I know that there was a relationship there with Cherokee Nation, but that's what I was thinking too. But I didn't want to absolutely confirm, but that's what I was under the impression of too.
Well, I just know that it's been recognized and unrecognized. I mean, it's been, and I've not really known yet, even though we worked with members of the Delaware tribe, if they were federally recognized or not.
The Federal Register has the consistent list that we all look to for who's federally recognized. It does change, but not dramatically over time. When we say there are 39 tribes in Oklahoma, the tribe that's not federally recognized, when we say that, is the Uchi tribe. The 38 are listed here. But there's a lot of other tribes that are hoping to apply for federal recognition. I have in another training I do, I have a long list of other tribes right here in our own state that are hoping at some point to get that. But really what's important to remember is that's more of a kind of, I almost think of it as a payment mechanism through Bureau of Indian Affairs. tribes don't put as much concern about that federal recognition. Some feel that that actually takes away. So even if you were working with someone who's not federally recognized for accreditation purposes, I don't think that's really, yeah. Yeah, I wouldn't be as concerned about that.
I think we have time for one more question. Lucretia?
I just have a question, either me for Sally or for Tom, but we kind of hear just in different conversations with either Sally or like hearing Tom talk about, or like Laura saying, you know, there are tribes that are considering the accreditation process. Is anyone actually compiling a list of those that are considering thinking about going through it? Because I think it'd be kind of helpful from the collaboration standpoint, or do we know kind of where that maybe stands?
I know that for us, it's just our perspective and just knowing some, you know, the bigger tribes are probably going to be the ones that are more ready. Chickasaws, Choctaws, Creek Nation, those bigger ones, but and Choctaw. So I think that would be a good place to go. And again, it all has to go back to public health infrastructure. They're going to be the ones that are most closely or closest to being able to have that system in place, because you do have to have an infrastructure in place in order to proceed with accreditation. Again, and that's kind of, it took us a good year and a half to kind of get that system solidified, because you have to have different protocols and whatnot. And so there's kind of like, in my head, I have been thinking that there's probably kind of a tier system, but that would be a good idea to be able to maybe start collecting that data and that information and to send that out to the state and local health departments. But again, I think that tier would be based on public health accreditation. I do know that I've had smaller tribes interested, and it might just be one or two people interested, but they will even say, well, you know, we don't have that infrastructure. But so I still think not to, you know, alienate them and include them. But again, the ones that are probably going to be going forth in the next year or two is probably going to be those bigger tribes with a health system in place.
Well, thank you, Laura, and I concur. Here's another thought. We advocate as a tribal epidemiology center that a lot of the tribes that aren't considering accreditation are going to be impacted by accreditation, or should be. So they have a dog in the fight. If a local health department, a state health department, I think it's mandatory that there will be outreach to those tribal people. So we, as a public health entity, an epicenter, a data entity, become involved. Sometimes, maybe IHS is involved as well from the federal perspective with information and data. So back to like Anna's area, the counties that she serves, those 5 tribes up there, if a county is looking for accreditation, the impact's going to be with those tribal people. So therefore, you're going to have to do some outreach. And that's when your effort needs to be given. How do we coordinate information specific for the tribes? One last thought on that. When you get tribe-specific information and collections of data, you want to be careful on how you disseminate that information, because we've been instructed that when you release tribal-specific information, first of all, do you own it? Can you do it? Tribes believe they are a sovereign, a government entity. They own that data. So you want to be certain that you communicated and you have something in writing from that tribe to protect yourself, because it could be a HIPAA violation, if something negative that could impact the tribe. But it's just to build good rapport. And I don't, but anyway, Sally, did you have a comment?
No.
Okay. No?
Great. Thank you to all of our panelists. Very good information. Let's just give them a hand. If you want to take a quick, maybe 3 to 5 minute break, and then we'll get right back into it. Thank you.